To start? Okay, thanks for coming, everyone.
You have to talk about.
Okay, that's right. So I would ask to talk about some of the federal impacts on healthcare, Medicaid, and insurance that are happening and how it will affect us in New Mexico. My name is Janis Gonzales. I'm a pediatrician, but I spent the last 20 years mostly working in public health, Department of Health, and then I left for 3 years to be the chief medical officer at the early childhood department, but then I went back to public health. So I'm still there. And this is not an official Department of Health presentation. Okay, so what we're going to cover is a brief overview of New Mexico Medicaid and some of the unique features that we have here in New Mexico that affect our healthcare landscape, some of which are really good that we're lucky to have. And then the federal budget reconciliation bill, what happened with that, how that changes some of the things and how we have to respond to that. And then I wanted to cover what's happening in terms of support for rural health, because it's kind of been confusing. There's two very similarly named programs that even in DOH, a lot of people are confused about. And then there was a request to add the recent vaccine changes. So there's a little bit on that. And then opportunities for advocacy. It's coming up as we have a session coming up. Right. So, Medicaid is very, very important to New Mexico. So we have about 2.2 million people in New Mexico, and almost 900,000 of them are currently on Medicaid. It fluctuates up and down. It was a little higher during the peak of COVID, but you know, that's 42% of the population, and it is the highest percentage of any state in the U.S. Yeah, and the same goes for children. We have the highest percentage of children on Medicaid of any state in the United States. Almost 300,000 children. So changes to Medicaid really impact New Mexicans and the healthcare system in New Mexico. You know, which is what I want people to understand is that this impacts everyone. Even if you're not on Medicaid, you've never been on Medicaid, it's still going to impact you because it impacts the entire infrastructure. You know, our system in New Mexico is so dependent on this Medicaid, right? Because all these people have Medicaid. It also pays for over 60% of births in New Mexico and 67% of nursing home residents. So, and the other important piece of that is that most of that money is federal, right? 83% is federal and 17% is state funded. Because we have a really high match, because we have a really high poverty rate. So the state match varies by state depending on poverty rate. So, and other factors, but so total Medicaid spending in New Mexico is $8.1 billion, and 83% of that is federal. It all flows through the state agency, the healthcare authority, but yeah, most of it, for good or bad, comes from the feds. So in some ways that's good, in some ways that's not good, because it makes us very dependent on them. The other thing to know, there's a lot more to Medicaid than what I'm going to cover, but these are just like pieces that I thought were critical to know. A lot of our Medicaid programs operate through a waiver, which means we have to ask the federal government, CMS, Center for Medicaid and Medicare Services, which is part of HHS, our PACE agency. We have to ask CMS for approval of a waiver every 5 years to do these things. So there's a lot of things in the waiver, but some of the more critical ones are that it sets up our managed care system. almost everyone on Medicaid in New Mexico is on managed care. Native Americans are on fee-for-service. There's a few other exceptions, but it's pretty much a managed care system, right? And that is all outlined in the waiver. So that's how we set up our system, and that's why every few years they put out new contracts, and the managed care organizations might change, right? So at one point it's United and Presbyterian and Blue Cross, and then the next time it might be, something else, right? And then there's also specific programs for children in there. The Medicaid funded home visiting is in the waiver. That was approved as a pilot in the 1115 waiver. And then the more recent one is the continuous coverage for children. It's really, really good. We got continuous coverage for children to age 6, which means they don't have to reapply. The parents don't have to reapply. So if a baby gets on Medicaid, they are covered up to age 6 without having to continuously be enrolled after baby. Yeah. And so because this waiver was already approved, we still have that continuous coverage. Hopefully that will not be pulled back, but at this point it has not. So we still have that, which is great. And then there's some stuff in there about Medicaid services for justice involved, providing Medicaid coverage after they get out of the justice system. There's traditional healing benefits for Native Americans, home delivered meals pilot program. There's a lot of different pilot programs in there. The closed loop referral system, I don't know if anyone's heard of that. That's been in development for a couple of years. It's a system where anyone in the community agencies, or even individuals can refer someone for services, and then the closed loop part is that you actually get information back showing you, yes, they did get the service, or they did enroll, or whatever. Whereas before, you could refer people, and then you might never know what happened. So that's in development, and that was also approved through the waiver. And then there's some graduate medical education funding in there. Those are grant programs to increase the number of primary care residencies in New Mexico, so that we can try to train more primary care physicians. And studies show that if you train them here, you tend to retain them. So we're trying to train and then retain primary care physicians, which we all know we need. That's all in there, and then there's other things in there too. Okay, this might be the most important slide in the whole thing, because really, I mean, it kind of impressed me when I put this together. I was like, wow, New Mexico has actually done a lot to prepare for what we're seeing right now on the federal level. We've had some really visionary legislators, especially Debbie Armstrong. She did a lot of this before she retired. So in some ways, our state is better prepared than a lot of other states for these things. So the first one, the oldest one, is New Mexico Medical Insurance Pool. It's been here in existence since 1987. It's also called the High Risk Pool. So it was originally established because, if you remember, before the ACA, Affordable Care Act, was passed in 2010 under Obama, before that, insurance companies could deny you insurance. I mean, really, any pre-existing condition that you had. If you had any kind of medical condition, they could just say, no, we're not going to cover you. It's almost hard to believe now. What? But they did. And so that's why the medical insurance pool was established, was to provide insurance for people who were considered uninsurable. All you had to do was show that you were denied for insurance coverage, and then you could get insurance through the pool. The important thing now is that the pool is really the only way currently that anyone who's undocumented can purchase insurance in New Mexico. I mean, they could try to get a private plan. I guess they could try to get a private plan. But New Mexico Medical Insurance Pool has a low income plan. So that's gonna be the lower cost than anything you could get privately. So, when we see someone, like for instance, at DOH, we have a program called Children's Medical Services that serves children with chronic medical conditions of all kinds. And some of those families aren't documented. Small percentage, but some of them. They come, their child has an illness, they don't have insurance, they're not eligible for Medicaid. So they come to CMS. And we put them on the pool. So the program pays the premium for the child to get insurance through the pool. And then they get full insurance, which is way more than we could ever cover through our little program. But we can cover the premium costs. You know, we couldn't cover the cost of a child with cancer to get treated at UNM, right? It's just hundreds of thousands of dollars. CMS doesn't have that, or CMS, the DOH program. Not to be confused with the federal CMS. But we can cover the cost of premiums, you know, it's like, I don't know, $5,000 or something for the year, right? So that's what we do for the kids that cannot get Medicaid, cannot get anything else. So it's really, really important. And the key thing here is that a lot of states got rid of their high-risk pool when ACA was passed. We didn't, because we had leaders like that who said, no, we're going to need this again. You know, we might need this again, and they kept it going. So that's really important. Then we do have, so under the ACA, every state had the option of setting up their own website for people to go to apply for coverage under the ACA, right? Just to be clear, so ACA, Health Insurance Exchange, BWell-NM, those are all referring to the same thing. Those are all referring to insurance that people can get under the ACA. Okay. So every state has a health insurance exchange, but some states opted to use the federal website. We opted to have our own BWell-NM state website. Right? So either way, people are going on and getting these same, you know, kind of ACA plans. But the difference is we control this website, right? We're not dependent on whatever the government decides to do with their ACA website. So to me, that's another thing. Like, oh, that shows foresight, right? Like we still control BWell-NM. We can put what we want on the website. Then there's a Medicaid Trust Fund. This is the newest one. This was just established in the last session, 2025. And the idea with this is that they put kind of seed money into this fund with the expectation that it would grow over the next few years and then be a source to help pay for Medicaid in case the federal government decreases their match, right? Decreases the amount of money they're going to get in Mexico for Medicaid. I mean, they can do that in different ways, but most commonly they would change their percentage that they're going to pay. It will make it safe. In Mexico, you're currently paying 17%, but now you're going to have to pay 30%. They can do that. And so this trust fund was set up to try to help that. So, I mean, it still needs to build, but it's going to be a big help. So there's that. And then there's some healthcare cost analyses and reports that are coming out. They're going to be coming out in June. Those are also funded by the legislature to try to give us more information about what else we might need to do to help people in New Mexico with costs of healthcare. Then there's this Medicaid Forward program that I will talk more about, which is basically a Medicaid buy-in. So people who aren't eligible for Medicaid can buy it. There's a healthcare affordability fund, which again was set up with the purpose of helping make healthcare more affordable for New Mexicans. And then there's the rural health grants that will cover toward that. Okay, so the Medicaid Forward Plan. This let's see, it was first brought up I think around 2020, but the first legislative action was in 2023. And what they did was they said to the HCA, Healthcare Authority, they said, we want you to study this, and come up with, a report, of what the impact would be and how it could be done in New Mexico. So again, this is still people, above the Medicaid threshold, which is, there's different categories, but generally it's 133% of poverty level. If you're above that, you would be able to buy into Medicaid, even though you're not, quote, eligible for, currently for Medicaid. So that happened in 23, and then in 25, there was a bill to actually try to implement it, to say, yes, go ahead and do this, HCA. That one didn't pass, and I'm not sure if it's gonna come back in this session. I haven't seen it yet, but there haven't been a lot of pre-filed bills yet, so it definitely could still come up. So what HCA would need to do is what's called a state plan amendment, or a SPA. And they would need to make an amendment to their state plan to open Medicaid to residents over 133% of federal poverty level, and then establish premiums and cost sharing for that group. I think, well, I shouldn't say, I'm not sure what that's going to be, because it hasn't really been decided yet. But the combined premiums and out-of-pocket spending is supposed to be limited to no more than 5% of a family's income. And like the existing Medicaid program, it would be under the same FMAP, so it would be largely federal funds doing this, which is why it can't be open to undocumented. That's not a problem with it. So some states, like California, have developed like a state plan alongside Medicaid that's completely 100% state funded, and that way they can cover anyone if they're not under the federal restrictions. But this is not that. This would have the same qualifications that regular Medicaid has. It just allows people with higher incomes to buy into it. But that's good, because with the buying power of Medicaid, the premiums would be less than what people are paying now, especially now that the exchange premiums have gone up, which we'll get to. So this would be a lot cheaper for individuals and families and employers too, to use this instead of using the exchange. So what we anticipate is that if this passed, a lot of people would move from the exchange onto this. It would be optional, but it would be less expensive. So from that report, the report that ACA had Mercer do, it shows that the uninsured population is projected to decrease by 48%.
Yes, what is the percent of uninsured people now?
That's a good question. After the ACA, it dropped from around 20% to around 10%, but I think it's now more like back up to about 15%, roughly. Okay.
So 15% of our population is uninsured? Like no insurance.
Yep.
Wow.
And some of that is because of the affordability problem. Right? It's not that they're necessarily not eligible. Some of them are not eligible, but a lot of them can't afford it, and their jobs don't provide it, or they're, they're working like multiple part-time jobs, and part-time jobs don't provide it, or they're seasonal workers. So there's different reasons. So even after the ACA passed, as you know, there were a lot of compromises that had to be made, right, to get it passed on the federal level. And so it wasn't as affordable as some people wanted it to be. But it was something, and it wasn't, they couldn't deny anymore for pre-existing conditions, which was the big thing. That was like the main thing that they didn't want to give up, was that anybody with any pre-existing condition would be covered, right? But in exchange for that, it was slightly less affordable than people really wanted it to be. So in 2021, the New Mexico legislature passed this healthcare affordability fund. And what it does is it provides like a state level subsidy on top of the federal subsidy, so that it makes the exchange insurance more affordable for people in New Mexico. Just, just subsidizes the cost, lowers the cost. So, the insurance company still gets the same amount, but the person pays less. So, for example, in 2026, they're going to put 17 million into that to reduce premiums through June 30th for people enrolled in BWell, which that was done in the special session in October. The purpose of that was because they knew that the premiums were likely to jump up in January, which is what we saw. We still need more money in that fund so that we can continue to provide those subsidies if nothing changes on the ACA level or the Medicaid forward. It's kind of complicated because they're all related, but definitely still need to continue funding that healthcare affordability fund. Right now, what they're saying is the 17 million they appropriated will last through June 30th. That's not very long, 6 months from now. But again, it's a good thing that we have that, right? So New Mexico was able to use that fund to lower premiums for anyone on the exchange. Some other states like Colorado, I think Massachusetts, other states have also done some things to try to help, but none of those states have been able to lower the premiums for everyone. They've only been able to do a portion of it. So, so it's just another way that New Mexico has done really well. And then they're currently developing a DACA program because part of what the federal changes do is they go insurance group. Go under DACA. And so right now there's people at ACA working on developing this, and then that's gonna help people with DACA status who lost eligibility for Medicaid or the marketplace to be able to afford insurance. So it's kind of a separate plan just for that population, but it's being funded through this fund.
What is DACA stand for?
Deferred action for, what's the C? Somebody.
Oh, citizenship?
Deferred action for something.
Children? You're not talking about.
It's for kids who were, brought here, and they've grown up here. They were brought here, they weren't born here, but they were brought here when they were young. They've grown up here, they've gone to school here, they want citizenship.
Right.
Yeah. Sorry. Can't remember what.
I'm sorry, I just didn't know what
Okay.
that means.
Okay, so how did we get?
Action for childhood arrivals.
Thank you. Exactly. Childhood arrivals. So they arrived as children. Right? They arrived as children. They grew up here. They're part of our world.
Thank you.
Yes. Okay. No, that's a good question. Some of the acronyms. If I say an acronym and you don't know, please ask. Okay, so this is what we're trying to respond to, right? This, I'm not going to call it what they call it because it's not really a beautiful thing, but it's the federal reconciliation bill. It was passed 6 months ago, also called HR 1. And what it did was, well, we did a lot of things, but in terms of healthcare, it put restrictions on things like eligibility, created more workforce requirements, more paperwork, more administrative requirements. It also changed the way states can finance their share of the Medicaid costs. And so, we have to make that 70%, right? So states have various ways of trying to do that. A lot of it is through taxes. So they said, well, we even want to control that. Even though it's on the state side, we're going to try to control that. So they put stuff in there, language in there about how the states can or cannot fund their portion of Medicaid. And also changes coverage for non-citizens, even people who are in the process of citizenship or refugees and asylees who have traditionally always been covered by Medicaid. It puts restrictions on those as well. Okay, this is the timeline. So July 3rd, 2025 is when Congress passes H.R. 1, signed by the President July 4th. October 1st, 2025, there were a couple things that went into effect, like SNAP work requirements. I'm not really clear on all the SNAP stuff, so I didn't include that. More on the health side. Then, as you can see, it jumps a whole year, right? So then nothing really happens until October 1st, 2026. That's when the eligibility changes happen for non-citizens. Then December 2026 is when you start seeing things like 6-month redeterminations for Medicaid instead of being able to go a year, or limiting retroactive coverage. So right now, if someone applies for Medicaid and they're already sick and they've maybe had a couple hospital visits, in the past month, and the hospital told them you should apply for Medicaid. Medicaid provides retroactive coverage, so you can go back up to 90 days right now and cover those bills, that happened before the person applied for Medicaid. Well, this is going to change that. It's going to go down to 60 days for some people and 30 days for other people. Sorry, I can't remember which group is which, but definitely decreases that time that Medicaid can cover retroactively. It also, this is where the work requirements come in, so there's going to be, which we're going to talk about more, but I just want you to see the timeline here. So you can see that all these big things hit right after the midterms. Midterms are going to be November 26th. December 26th is when all this stuff starts happening. And then January 2027, there's more administrative stuff. A lot of this just puts extra burden on the healthcare authority, right? So like to set up work requirements, they have to hire a bunch more people and set up a system to check on work requirements and to do all these redeterminations. They need more staff to do the more frequent redeterminations, and then in January 2027, they have to start doing more frequent reviews of what's called the death master, which is just like, making sure that people who died are taken off the rolls and updating the address information. So all of this is like more administrative burden, more cost to ACA, which means, of course, more cost to us, because ACA is a state agency that's funded by us. And then member cost sharing begins in October 2028. So they just delayed a lot of this stuff. But it's still gonna hit. So in terms of the work requirements, this mainly impacts what we call the expansion population. So if you remember, the Affordable Care Act passed in 2010. Part of that was that states had the option to expand Medicaid to cover adults from 19 to 64, healthy adults. We're not talking about people on disability, that's always been covered. But the healthy adult population, they had an option to expand that. Healthy adults who are under 133% federal poverty level. Some states did, some states didn't. Mexico did expand. We were an expansion state, even though we had a Republican governor at the time, Susana Martinez. So that passed in January 2014. This group, though, is kind of, in a lot of ways, is a target of this bill, HR 1. So a lot of these things really impact that expansion population. Work requirements is one of them. So they're going to have to show 80 hours a month of work, community service, or part-time education, or a combination of those things. Key thing is that most of these people are already working, but a lot of them have multiple low-wage jobs, seasonal work, part-time work. It's hard to get the documentation together for all those things. It's hard to have to keep submitting it every 6 months. Yeah. So there's this myth that, oh, these people aren't working and this will make them get to work. No, most of them are working. It's just gonna make it harder for people to continue to stay on Medicaid, to not fall off of Medicaid, you know, because, and again, like if you're working multiple part-time jobs, how much time do you have to do all this? And you have to go in. And then, that wasn't enough. Then they said, if a person is denied or disenrolled due to work requirements, like they don't get their paperwork in on time, so they're disenrolled, they need to file a new application to reapply for Medicaid, and they're ineligible for federal subsidies on mission. So they can't even move from Medicaid to mission. So obviously what this will do is just increase the uninsured population, at least temporarily, as people go on and off, you know.
Janice,
Yeah,
as I'm thinking of it, I'm thinking how many people in my community that are just trying to survive and they accept cash under the table. How does that, they're,
We can't.
in order to eat, they're having to
yeah,
do that.
if you can't show documentation of this,
Yeah,
80 hours a month,
Yeah.
of some of this, of some combination of this. Yeah. Yeah. Sorry, I'm really trying not to be political, but some of this is just, it's really clear what the impact is.
yeah.
Okay. And then the redetermination, as I mentioned, is going to be every 6 months now. For the expansion population, I don't know why this is such a target, but it is.
What's the expansion?
Oh, I forgot to mention, with the work requirements, the states do have an option to delay from 2026 to 2028. Like if they need more time to set up a system or something. I'm not sure what our state's doing. I'm not in those conversations. So I haven't heard anything about that New Mexico wants to delay it, but they have an option. With the redetermination, they do not have an option. It has to start December 31st, 2026. The only exemption is for territories and again, Native American population.
So when it says Native American population, Janis, is that if you have any, is there like a percentage of Native American that you must be able to prove that you are? Or
I think you have to be enrolled in a tribe. That's
oh, okay, that's really what that means. Okay.
not percentage.
Okay.
Okay. And then they also made changes to the non-citizen coverage, like I mentioned. So part of what we do for non-citizens through Medicaid is what's called emergency Medicaid services. So if somebody who's not eligible for Medicaid because of their status has a true emergency and goes to the emergency room, they can apply for this emergency Medicaid. And it's basically just a way to help the hospitals, right? Because otherwise they would have to eat all this care, because hospitals have to provide emergency care. If you come in and you're bleeding out, they have to help you, right? And they can't just turn you away because you don't have insurance. So this has been in place for a long time, this emergency Medicaid, but what they're doing is they're reducing the federal percentage that they pay for it. Some other states will have to pick that up. And that's one of the earlier things. It starts in October of 2026. Then ending Medicaid funding for refugees, asylums, and other non-citizens. So again, this has been a long time thing that we've done. When people come in as a refugee or they apply for asylum, those are legal statuses, right? Those are legal.
Yeah.
And they come in and they're following the legal process. They have been eligible for Medicaid in the past. They're taking that away. This is a lot. Okay, and this is what I was talking about in terms of how states fund their portion of Medicaid. All states except Alaska currently use provider taxes to help finance their share of Medicaid expenditure. This HR 1 bill puts limits on states in terms of the provider taxes. It says you cannot put into place any new provider taxes to help cover these new costs that we're putting on you.
And whose idea was that? That just sounds like it is.
Yeah, you would think states could do whatever they want to fund their portion, but no, they even want to say, no, you can't do that. You cannot put any new provider tax or increases to existing rates for taxes enacted prior to July 4th, 2025, which you recall was when the president signed HR 1.
Were there any ideas of how you might be able to fund that?
Well, that's why we developed that Medicaid trust fund. So we can use that to try to fill in the gap. But again, it was developed with the hope that we would have a few years for it to grow. It was just implemented last session, so it hasn't had that much time to grow. And then again, it changed. Okay, so then it also changes the limit on how much provider tax revenue a state can use to draw down federal Medicaid funds, and it specifically makes a distinction between expansion states and non-expansion states. So non-expansion states, the percentage stays at 6%, which is what it is now, or what it will start at. But for expansion states like us, it starts at 6% and then decreases over time to 3.5%. So again, it's like this targeting of the expansion population. Expansion states are targeted. I don't know if it's just because like expansion of Medicaid was part of the ACA and they don't like the ACA, so they're like targeting expansion. I don't know, but it's clearly a target. So that's why we have to look for other ways to fund it. Okay, so then,
I'm sorry, say your boy, the expansion population, what exactly is that?
sorry, so that goes back to that, when states had the option to expand Medicaid after the ACA passed, states were given the option to develop, implement, what was called Medicaid expansion. And what that did was it created like a new category of Medicaid for healthy adults, 19 to 64, under 133% of federal poverty level. So those are the people that are low income, but currently or previously didn't fit into any other Medicaid category. Because Medicaid prior to that was mostly for children, disabled, specific populations like that. It did not cover healthy adults. It just didn't. So that was the whole idea, was, well, yeah, they're healthy, but they're low income, they still need help with medical coverage, so let's cover them, right? And so, and a lot of states did extend. I'm sorry, I don't know the number that did and didn't, but I think it was the majority that did expand. But I think because it was part of the ACA, that you just don't like it, I don't know.
But more importantly, they don't like Obama.
Yeah, there you go.
And with the orange one and his cult
Yeah.
cruelty is the point.
Exactly. Exactly. Okay. So those are the changes to Medicaid, on the Medicaid side. Everything we've been talking about was on the Medicaid side. Now this is what's going to happen on the exchange side, right? ACA, health insurance exchange, UL, all the same thing. They're also making it harder to enroll or re-enroll on the exchange. So similar to what they're doing to Medicaid, right? It's going to be harder to enroll or re-enroll on the exchange as well. I was talking that, I was saying earlier, like, I really don't understand the point, because it just seems like, if you look at these things, it seems like the goal would be more uninsured people, which is definitely what's going to happen. But why? Why would that be a goal? To have more uninsured people? I don't understand that. But that's what's going to happen. So again, the individuals with DACA status are going to be excluded as of next October because they're no longer considered lawfully present. Even lawfully present permanent residents like green card holders, refugees, and friends, are still not gonna qualify for the tax credits, so they may be able to continue to get coverage on the exchange, but they won't get the federal tax credits. And icing on the cake, they also cut the funding for the navigators. So when this whole exchange system was set up, one of the things that was part of that was hiring navigators to help people, because insurance is so complicated, right? And so if you call Be Well, you can talk to a navigator who will help walk you through it, and figure out what plan is best for you. And, should you be applying to Medicaid, or should you apply to Be Well, or, and then even on Be Well, there's different levels, right? There's different plans. And so the navigators help with all this. Great, it's a great thing. They help people get insurance. But now we're cutting the navigator funding by 90%.
No.
So they won't
Just
keep.
like that.
So again, the state will, either the states will have to pick that up if they want to keep helping people, or they'll have less navigators. Sorry, fewer navigators.
But they want people to find jobs.
Yeah. And people
Yeah, it's
losing their
cruelty
jobs.
and racism under the guise of pick yourself up from your footsteps
Yes.
or whatever.
So I think we should be clear, the goal is to reduce the amount of federal funding for healthcare to justify a tax reduction. And you target the population that is the least likely to vote and least likely to support your opposition.
Because you have power. Right, well,
That's
that's
the bottom line. And I want to point out that that wasn't Janis saying that was Ricky Anderson.
Thank you. Thank you.
Kind of hard not to be political, isn't it?
It is, because I want to explain what's really happening, but it's kind of hard to explain.
But Janis, I would expect in the healthcare authority's budget request at the coming session, maybe funding for more navigators, if it's going to be cut. We'll see. I don't know.
We'll see. I mean, their budget request is going to be huge, because they have to do so much of this work. Okay, so.
I just want to be the person that understands insurance myself.
Yeah, are we good on time?
You just hand them a stack of cards and hope it. And bill that when it comes in, there is no.
We're good on time? Okay. Let me know if I need to speed up. Okay. Okay, so, after you've heard all that, to try to summarize, what these impacts are going to be. Congressional Budget Office, which is a supposedly neutral agency, I think it's known as something, estimates that the coverage loss will be 10 million people will lose coverage on either Medicaid or the marketplace because of all these changes that we talked about, right? Having to reapply, all the other things they have to show. Yeah. Bringing the total uninsured to about 15 million, which is the pre-ACA levels, before we did all this work to insure people. We're just going backwards. Rural hospitals and federally qualified health centers rely heavily on Medicaid revenue. That is so important. Everyone in New Mexico needs to understand this, because that's why, yes, New Mexico has done a lot of great things, so in some ways we're in better shape, but in other ways we're in worse shape than other states, because our system, we're a very rural state. Our system really relies on rural hospitals and FQHCs, so that are, providing primary care throughout the state. And they're going to be really impacted by this, because as people lose coverage, they're still going to be going in for care. Yes, they'll delay care, but eventually they'll go in, right? And then they won't have insurance to pay for that care. And so these, the whole health infrastructure is going to be impacted by having to provide uncompensated care. The New Mexico Hospital Association already has estimated that 6 to 8 rural hospitals could close within the next 24 months. Devastating to a state like this. And
I
again,
wonder where the people working in those 6 to 8 hospitals, all those people are going to lose their jobs.
yeah,
So
if the hospital closes,
relocate, or then you have more people.
in a lot of these rural communities, the hospital is the biggest employer, And so, yeah, you're right. It's just a snowball effect, the loss of jobs, and then people, you know, having to drive hours for care so that they won't get the care they need. Just a snowball effect. And again, when we lose these hospitals, and then places like UNM have to take up more and more and more of the burden, it's just gonna impact her for everyone. It's not just people on Medicaid, I can't say that enough, it's gonna impact everyone. And if FQAC is closed, same thing, you know, fewer primary care providers in our state, which we already don't have enough of. And just to be clear, you know, instituting copays and cost sharing and all the stuff that they want Medicaid to do has never been shown to deter people from seeking care. What it does is it just increases costs to the system. So, you know, the ACA is going to have to ask for more money to implement all these things. Yeah, it's just making it more costly to implement, but it's not going to really save anything on the care side. Okay, so how did we get here? So HR 1 passed, and then again, you know, as part of HR 1, right, they were, what some people wanted them to do when they were doing those debates for HR 1 was to include an extension of the subsidies that were put into place under Biden. Those are expanded subsidies from what originally was under the ACA. But they didn't do that. So then we got into this government shutdown, right? It lasted 43 days, the longest government shutdown in history. And it finally ended because they passed a continuing resolution to fund the government at current levels. But that resolution only goes through January 30th, which is about 2 weeks away. Yes. So now we're right back where we started, where we need another continuing resolution, or the government will shut down again on January 30th. It did not resolve the ACA issue. So the enhanced premium subsidies did expire on December 31st. They did, that's right. The CR only passed because they were able to get 4 Democrats to vote for it after Senate Majority Leader agreed to have a vote. He said, we will hold a vote on extending subsidies. That was how they got people to sign up. It was only a few, but it was enough. So Congress adjourned on December 18th with no solution. There were 2 proposals that were proposed in the Senate, and neither one passed. In the House, 4 Republicans teamed up with Democrats on a discharge petition to force a vote, because the vote that was promised, of course, didn't happen. So they put in this petition which forces a vote, but it forces a vote after they get back from break. So that vote occurred on last Thursday, January 8th. So enhanced subsidies expired December 31st. Oh, and I should have mentioned, the exchange, if you don't know, the exchange has a certain enrollment period. So you can only apply between November 15th and November 1st and January 15th, I think it is, every year. That's open enrollment. That's when anyone can apply for the exchange. And it's the same for the higher school. After that, you have to have what's called a qualifying life event. So something changes in your life. You have a baby, married, something. But then you can apply for what you. But otherwise, you have to do it during open enrollment, or you have to wait a year. So the subsidies expired, and then people that are still applying now have higher rates. We've already been hearing from people who are saying, yeah, my rates are like twice what they were last year. Okay, so this has already happened. So they came back, they had to vote because of that discharge petition. The House voted, they got 17 Republicans to vote with Democrats, which is good, but it still has to pass in the Senate. We're not going to do this. And I have no idea what's going to happen there.
And December, the person,
What?
Oh, yeah, and then it has to be something like,
It has to be done in the next 2 weeks.
that'll happen.
Okay, so that's all the federal stuff. So then, okay, so obviously, right, like you said, we're a rural state, a lot of this is going to impact our rural hospitals. So what's being done to support that? So part of what they did was they put funding for rural healthcare into HR1 as a way of saying, hey, we know that, you know, this is going to impact rural healthcare and rural hospitals, and so we're going to take care of that by doing this. Well, it doesn't take care of it. The money that they put in there for the rural program doesn't come close to making up for all these other cuts that are happening. But it looks good on people. So that's the Rural Healthcare Transformation Fund. That's a big part of HR1. New Mexico also has a Rural Healthcare Delivery Fund. I just wanted to go through these real quick because it's just really confusing because the names ended up being, we had ours first, by the way. Our fund was set up first. It was set up a couple of years ago. Okay, so this is the state fund, Rural Healthcare Delivery Fund. It was established in 2023 by the legislature. There was another $50 million appropriated in that last special session in October. We just had, they just put out $20 million in grants in December to 32 rural health organizations. It can be used for new or expanded services, so it's pretty broad. So rural entities like rural hospitals and FQHCs applied for this funding. And this is administered also by HCA. Rural Healthcare Transformation Fund is the one that's part of the federal HR1. It was established with a $50 billion fund. Sounds like a lot, but it's shared by all the states. States had to apply. Awards were made in December. New Mexico was awarded $211 million, but it's over 4 years.
Oh my God.
Yeah. and there are restrictions on how it can be used. I don't remember all the details on that, but that's, yeah. So the point is, like, it doesn't cover everything that we're losing. But between those two funds, you know, those are both trying to address these issues that we talked about with rural healthcare. Whether or not it will be able to keep the rural hospitals from closing, I don't know. We have to look and see. Okay. So I think the person who asked for this isn't actually here, but do you want me to do the vaccine part? Yeah. Okay. Probably know that HHS has been making changes gradually over the last 6 months. HHS is under Kennedy.
Well, I don't really give a damn about it. So I'll see that.
More importantly, CDC is under HHS. CDC and CMS, Medicare, Medicaid, those are all under HHS, right? So they are basically telling CDC what to do with vaccines. These decisions aren't being made at CDC by, you know, experts in vaccines. So most recently this week, they put out a new schedule for children's vaccines. They created, instead of just a list of recommended vaccines for all children, which is what we've had forever, they created 3 different categories. All children, recommended for all children, recommended for children with high-risk conditions, and then this third category that they call shared decision-making. You know, the important thing is, as a pediatrician, I can tell you, we have always done shared decision-making. I mean, shared decision-making is really just the doctor is supposed to talk to the patient about the vaccine, why they think they should get it, what are their concerns about it, you know, answer the questions, like those kind of things. That's always been the way we operate. So by creating this special category, it's just kind of trying to say, like, this isn't happening. I don't know, but what it really does is it makes people question even more, you know, the vaccine schedule. Like, oh, these aren't really recommended anymore. It's just something that we're supposed to maybe talk about with our doctors. So it creates more confusion, it creates doubt, people start doubting the vaccine schedule. And most importantly, these changes were not made based on any new evidence of safety concerns. Nothing, there's nothing new that they presented that caused this. It's just because they just wanted to do this.
Janis, have they told you as a pediatrician what you're allowed to say? Like in women's health care, they tell the docs they have to basically tell women lies if they want to go in for abortion care or something. Or have you been told what you're allowed to say and what you're not allowed to say to people if they ask you?
No, not yet.
Probably coming.
And then there haven't been as many changes on the adult side. RSV is still recommended for adults 75 and over and high risk over 50. COVID, they did move to shared decision making. So for both groups, they did that for COVID and flu. MMR, the only change they made to MMR is they said don't use the MMR-B combination, which is a combination of measles, mumps, rubella, and chickenpox. But it's not used very much anyway, so that doesn't have a lot of impact. And then important thing is that when they put this out, they were quick to say, but insurance is still going to cover everything. So when they put out the schedule this past week, at the same time they put out the schedule, they said insurance is still going to cover all of these categories. I think we'll wait and see, right? Because that what they tend to do is like they'll do something, and then they'll do something else, and then they'll do something else. So who knows? And you know how insurance companies are always pushing back on coverage, right? So I could see at some point they might say, you know, we only cover the recommended group, and we don't cover this group, you know. But so far, no, everything's covered. Yeah.
I got the MMR last year when measles had its outbreak here, and my insurance did not cover
Well, they were supposed to.
it. Yeah, well.
They were supposed to. Did you appeal it?
Pardon?
Did you appeal it?
No, I just ate it.
I think you could have. Yeah, they really were supposed to.
And I got RSV when I was 60. I'm nowhere close to 75.
Okay.
Is it one shot does all work?
Yeah. One
Once
shot.
you've had it,
Yeah.
you don't have to.
No, just one shot for that one.
Janis, it is 10:45.
10:45. Okay. DOH has said that their recommendation is to continue the old schedule. AAP, American Academy of Pediatrics, same thing. Recommendation is to continue the old schedule. Office of Insurance in New Mexico has also said that they don't anticipate any change in coverage. So that's just where we are right now with the vaccine. Areas for advocacy. So I think, you know, it's obvious we need to push to continue funding the Healthcare Affordability Fund, the Medicaid Trust Fund, and the Rural Health Care Fund. We're going to need those. So anything you can do to advocate for those, we need to fund those to the max as much as we can. We do need legislation to enact Medicaid forward if it's going to happen. So as of right now, you know, it didn't pass last year. So they have this study that they did, but they don't have the authority to actually implement it without new legislation saying, yes, implement it. So that's another thing. In terms of bills this session, very little has been pre-filed. We probably don't even need to spend time on those. There's some interstate compacts that would just allow practitioners from other states to be able to work in New Mexico without getting relicensed.
Yeah.
So those are the main things, yeah. And that's been tried for the last couple of years, and for some reason haven't gotten to. But it's gonna be there then. Okay. I was just gonna go through this, but you probably already know how to find a bill. You know, it's on. You go to the website. You can look for any specific bill. You can look by topic. You can put in under a keyword. You can just put in health. See all the bills related to health. So it's kind of nice. You can search for all that stuff. And then the timeline. January 20th at noon, it will open. They have till February 4th to introduce new bills, or done bills, and then the session ends February 19th. So it's really quick. It's a short session this year. It's only budget related or things that the governor says are urgent. And then May 20th is the effective date of everything that passes that doesn't have an emergency clause. Okay. I'm sorry.